Okay, everybody's just coming into the meeting room here now, and while everyone's coming in, I'll just get started. We're here tonight to share a cup of tea. I have a sparkling water drink, so it's kind of hot for tea, but join us today for an event that we have on a quarterly basis. And the agenda for today is I'll go over a couple of announcements. I'll share some information about the cup of tea, a couple of housekeeping things, and then we'll go to our article summary. And after the article summary, we'll have a chance to have a good group discussion. We do have to finish at 9. There's another meeting starting, so we'll make sure we stick to our time. So what I wanted to share, we have a lot of great people joining us today. Some know about our retinoblastoma research community and some don't. I just wanted to encourage everyone to hear about it and then join it. So the retinoblastoma research community is a renaming of what we used to call the retinoblastoma research registry. And this is created to connect people who are personally or professionally connected to retinoblastoma and are interested in research. This is an international group, and we welcome anybody who's connected to retinoblastoma. This includes patients, their family and friends, researchers, and health professionals. So the link is in the chat, and you can go through the link to sign up. This way, you'll always be informed of events, information, and other great things. So make sure you sign up and share the link with others as well. The other announcement is we have a Priority 3 working group. In 2017, you might have heard about the top 10 retinoblastoma research priorities that were established. And the priority number 3 is seeking to address the psychosocial needs of retinoblastoma survivors and families. So a working group has been working on this research project to address the priority. They helped create the study that is going to address it, and now we're working towards making sure that the recruitment is underway. So we're asking people who are interested or would like to learn more to join us for our next working group, which is tomorrow, Wednesday, July 20th at 3 p.m. Eastern Time. And if you're interested in joining us, please email me and I will forward you the meeting information. So the Cup of Tea is like a journal club. This is an event intended to bring the Canadian retinoblastoma community together for an informal discussion about a research article. Discussions center around articles which members of our Canadian Retinoblastoma Research Advisory Board, or CRAB, have created a plain language summary for. The past Cup of Tea recordings are available on our YouTube channel, and you can find that by typing retinoblastoma research in YouTube. And then building on the success of this event, we have the live event, we have the YouTube channel, and we're working on a podcast version as well, which was suggested at our latest retinoblastoma research symposium. So keep an eye out for that too. So how this is all developed is a patient selects an article, and a patient is being referred to in sort of a broad term, could be a parent, survivor, or another family member. Selects an article and is given guidance on how to read scientific articles and how to write plain language summaries. And the patient is then partnered with a healthcare professional to help them better understand the article, make sure that they have all their questions answered about it, and helps with a plain language summary. And once that is put together, the pair is then invited to present their information at a Cup of Tea event, which is what we're doing today. And then each step in itself has many little pieces to it, but this is a general idea of how we've gotten here today. So for today's Cup of Tea, we're going to discuss the article called Replacement Time of Custom Ocular Prosthesis in Children, a review article. You can find the summary of this article on our website. And just remember to make sure that you have the best view possible. Under view, if you choose speaker view, and then you can use the raise hand function to ask questions at the end of the presentation. So our speakers today who've created the plain language summary of this article are Talene Dorna, who's an educator. She's a wife, she's a mom of 3, and author of the book, The Extraordinary Eye. And Talene is also a longtime member of CRAB and participates in monthly working group calls and represents CRAB as an RB champion. And Matthew Milne is an ocularist at Archibald Maxillofacial Clinic, where he fits custom artificial eyes and scleral shells. Matthew's an active member of CRAB as well and enjoys attending the annual Retinoblastoma Research Symposium. So I'm going to pass it over to Talene to share with you her plain language summary. So Talene, if I'm going too slow, please let me know.
Okay, great. Thank you so much for that lovely introduction, Ivana. And thank you for everyone for attending tonight and taking time out of your evening to be here. So to get started, just to introduce you to my little family, you can go to the next slide. Thank you. As Ivana said, my name is Talene Dorna, and I'm an elementary teacher with the Toronto Catholic District School Board and a proud mother of 3 children. Sydney is my oldest, and she's 8.5 currently. Kaylee is 7, and Logan is my RB survivor. He is 5.5 years old and about to start SK in the fall. My husband, Serge, is a software developer and writes software for ultrasound machines for Philips. The first picture you see here on the screen is my family photographed in October 2017, just 3 months after my son's diagnosis at just 10 months old. The second picture was in June 2019 when my son was 2.5 years old. So in March 2021, I published my first storybook called The Extraordinary Eye. I was on a mission to raise awareness, normalize prosthetic eyes while trying to help take away any stigma associated with having a prosthetic eye. I wanted to help my son and children just like him feel acceptance and self-confidence. You can find my book on Amazon worldwide if you don't already have a copy for yourself. Also, feel free to follow me on Instagram. I'm currently working on another storybook about childhood anxiety and coping methods, along with teacher and parent resources. I think especially, having a child who's gone through the struggles of, retinoblastoma, the journey being unique for everyone, and some having a prosthetic eye, it can sometimes accompany some childhood anxiety in the aftermath. So I decided to focus on that as my next adventure in storybook writing. So my Instagram handle, you can follow me on Instagram. It's at Mrs.Talene Dorna. It's also linked for you in the presentation slides if Ivana shares that on the CRAB website later. You can take a look there as well. The first picture to the left, just for anybody who's has some visual impairment, the first picture to the left is a picture of myself holding my book. The second picture is a cover of my storybook, The Extraordinary Eye. And if you click on the picture, you can be taken to a link for the Amazon store. And just make sure you're in slideshow mode. The third picture is a screenshot of my Instagram profile. Okay. So diagnosis. So what led us to retinoblastoma? When my son was nearly 6 months old, he was diagnosed with unilateral non-hereditary retinoblastoma. Just 8 days after diagnosis, my son's left eye was enucleated as the tumor was quite large and within his peripheral view. A temporary prosthesis was inserted, and 6 weeks later, a custom prosthesis was made. Within our child's first year of having a prosthetic eye, we visited our ocularist numerous times for adjustments or infection-related reasons. My hope is that this article would answer the recommended number of times one would have to visit an ocularist within the first few years of receiving a prosthetic eye, how often the prosthesis should be maintained, adjusted, and changed completely, and what are the consequences in not doing so. So these are pictures of my son's glow. He had classic leukocoria, where the white pupil was shown glowing through the reflection of white light seen upon direct illumination of the fundus through the pupil, in contrast to the usual healthy red eye reflex. So these are just pictures of the glow found in my son's left eye, and that's what led us to our diagnosis. So the next slide is a picture of my little boy at 3 months post enucleation. Here he is just 1.5 months post custom prosthesis. So he 3 months after diagnosis, he had about 2 different types of prosthesis inserted. One was just one that was put in temporarily at the time of enucleation, and then 6 weeks later he had his custom prosthesis. And within that time, there was a lot of healing that was happening. So we had quite a few visits with Matthew to correct a few issues that he had. The next picture is my son again 2 years later, and on his second prosthesis. I'll be talking more about the 3 prosthetic eyes he's received over the course of the 5 years later in the presentation, and I'll also show a visual of how dramatically different the size has progressed over the course of time that he's had them. So some terms and definitions you will come across with this specific review article. Orbit, so the orbit is the cavity or socket of the skull in which the eye is situated. Orbit can refer to the bony socket, or it can also be used to imply the contents. Enucleation is the removal of the eye that leaves the eye, muscles, and remaining orbital contents intact. Ocularist, a person like Matthew who makes artificial eyes. Prosthesis, the meaning of prosthesis is an artificial device to replace or augment a missing or impaired part of the body. Ptosis, drooping of the upper eyelid due to paralysis or disease or as a congenital condition. Ophthalmic cavity, I can't pronounce that, an ophthalmic cavity or socket refers to an orbit that lacks an eye. So moving forward, some of the things that I pulled out of the article, the main research questions. So the authors of this article sought out to answer the replacement time needed for ocular prosthesis in children based on the rate of orbital growth related to age. The article discusses the optimal time to have the ocular prosthesis replaced and maintained in relevance to the research conducted to show which ages the most orbital growth occurs. This information will help give patients and their families clarity about the frequency required to have adjustments and replacements of prosthesis in children and the negative impacts in facial bone growth if not done so. Some of the methods that were used in this article, they analyzed the published literature on the replacement time of ocular prosthesis in children. Published articles up to November 30th, 2020 were analyzed. A total of 910 manuscripts were read through, and in the end, 7 manuscripts were selected for the study based on predefined inclusion and exclusion criteria. So, in conclusion, some main points that I took out of the article. Rapid growth of the orbit comes to an end by 15 years of age in boys and by 11 years in girls, with 95% of the growth of the adult orbit complete. Enucleating the orbit during the growth phase reduces the growth rate of that side, but does not stop the growth completely. X-ray images also showed a rapid increase in orbital volume till 3 years of age. All studies research showed that 75% of orbital growth is observed from 1 to 3 years of age, and the remaining 25% growth is observed from 4 to 16 years of age. Children with ocular prosthesis are recommended to be seen every 4 to 6 months for routine examination. Yearly replacement or relining of the prosthesis should always be assessed by the ocularist based on orbital change and growth. Various factors like patient comfort, age, signs, and clinical assessment should always be considered before relining or replacing the old prosthesis. And this study confirms that the most changes in orbital growth occur between the ages of 0 to 12 years of age, Therefore, custom ocular prostheses need to be changed till the age of 12 years based on the clinical evaluation and presence of symptoms in coordination with the facial growth. But of course, again, after that, on an as-needed basis or depending on the situation. The ocular prosthesis should also be checked every 6 months for fit, size, and comfort till the child is 8 years old, and really sticking to that specific timeline. So some discussion that was pulled from the article. The research states that the presence of a prosthesis is not necessary for normal bone growth, but rather for aesthetics of facial growth. It is essential that patients come in regularly for evaluation and assessment of ocular prosthesis in relation to facial growth and other contributing factors. Some factors include, but are not limited to, discomfort, loose fit, prosthesis rotation within the socket, discoloration of the prosthesis, lens symmetry, significant ptosis, which is again the drooping of the upper eyelid. These are just some to name a few. All the studies stress the fact that in growing children, the ocular prosthesis should be changed periodically over the period of years stated. But there are very few studies that can guide ocularists with proper guidelines as to how often a patient should come in for adjustments, relining, and or a complete replacement of the prosthesis. Nonetheless, the studies show that updating the prosthesis by adjusting, relining, and or replacing it is necessary for facial development to have symmetry and to avoid any issues in the growing orbit with the enucleated eye. I did create some infographics, and the next slide just shows just a visual. So just to show that boys do tend to take longer for orbital growth over females, and 95% of the growth is already complete by the teen years, with the majority of that growth happening from ages 1 to 3 years. And that was mentioned too in another study where 75% of that is complete by age 3. And then everything else happens like that. The 25% is left for it to be developed up until the teen years. But that's the slower part of the growth that happens. Taking a look at the next slide, here are some examples just taken from my own child. The first 2 images showing lens symmetry and ptosis are stock images, but the others are taken from emails I had actually sent to Matthew myself, our ocularist who's here with us today. And, you know, of all the issues we experienced in the first 3 years, these are just some of the pictures that we had sent him, anywhere from puffiness, discomfort, redness, irritation, infection, and discharge. These all needed medical care and attention, like relining or adjusting, and sometimes even antibiotic eye drops, which were really essential. It's also crucial to have regular appointments because they can truly prevent something before it can become a problem. And this is actually quite a story that I tell a lot of our friends. But one day my husband had gone upstairs to quickly grab something. And when he came down, he discovered that our son's prosthetic eye was missing, and it had fallen out, and he had put it in his mouth. And he was probably about 9 months old at the time. And one can imagine the fear a parent already has about small objects being around their child. And now something that is part of them can in fact become a choking hazard and endanger them. So his eye needed an adjustment, and a quick visit with our ocularist solved that issue. But it was quite frightening because now that's something else that we had to think about. So taking a look at the next slide, again, here's another visual to show how much change happens within the ocular orbit in the first 3 years of life compared to the remaining years leading up to the teens. And then again, the next visual again, 77% of the total orbit volume is achieved by age 5, which is the bony cavity of the skull, which houses the eyeball. And in this case, it would be the non-porous implant. So here's a quick overview of the replacement schedule of ocular prosthesis in children. In this study, there were 330 total participants. Children under 3 had a new prosthesis after 18 months. Children 3 to 12 years of age had 1 replaced after 21 months, and 12 to 16-year age group had 1 replaced after 26 months. Overall, a total of 41% had their eye replaced within the 18 to 21 month mark. Again, these numbers are just examples, but a child may require a new prosthesis sooner rather than later based on how often they require adjustments, as a prosthesis can only have so much wear based on what Matthew has explained to me as well. And Matthew will actually elaborate on that very shortly. But just to summarize everything in the next slide, in summary, having regular appointments prevent things like ptosis, aesthetic issues, symmetry, and malformation of orbital growth. Why is it important to keep up with regular appointments, especially under the age of 3, to promote congruent facial development, the high rate of orbital growth, the overall fit and comfort for the patient, and of course, social and emotional aspects that stem from having a prosthetic eye that looks and feels great, because that's important too. Just the overall comfort and how the patient feels in the end about themselves. And finally, the when. A patient should have their prosthetic eye refitted annually at the very least, checkups every 3 months for children under 3 years of age who have the highest rate of orbital growth, and children over the age of 3 to have their checkups every 4 to 6 months. The next slide shows my son's prosthesis over the years. So he received one at 6 months old, and then again at age 2, and again at age 4. And as you can see, there is significant growth between 6 months of age to age 2. And then age 4, you see another quite a bit of growth happening there as well. And the shape has even changed. So you went from like a nice oval to, a more of a, like not so symmetrical, like it just changed completely from 6 months to age 4. So a couple facts before I pass it on to Matthew. All the studies stress the fact that in growing children, the ocular prosthesis should be changed periodically over the period of years stated. But again, as I said earlier, there are very few studies that can guide ocularists with proper guidelines as to how often a patient should come in for adjustments. And studies do show that updating the prosthesis by adjusting it or replacing it is necessary so that the child can have that facial development to be congruent and to have that symmetry and to avoid any kind of issues where it may end up having some detrimental things in the future where surgery might be required to correct something. So some food for thought. In the United States, like unless you pay into a private health insurance provider, an ocular prosthesis can range anywhere from $2,000 to $8,000. It's again, the article does not have the authors of this review article have clearly stated the age groups for replacement time of ocular prosthesis in children. And based on the orbital growth rate and facial aesthetics, it would be helpful to apply this baseline to factor in socioeconomics of the patients involved. Unfortunately, the cost, again, as you can see here, it's quite a bit in the States, but in Canada, some provinces cover to a maximum of an approved list of ocularists, some ranging from 75 to 100% of the cost. And the remainder, 25%, is paid out of pocket, like in Ontario. But there are a few provinces that cover nothing at all, like I believe Matthew mentioned Saskatchewan and Manitoba. Matthew, did you want to elaborate on this and what could be the impacts that can have on a patient?
Absolutely. I mean, there's always a hey everyone, how's it doing? I was going to say that in terms of like the socioeconomic cost of this, I mean, it can be a dissuasive element to having prosthetic relined or refit or having a new prosthesis made. So, I mean, as an ocularist, I've always tried to promote for the Ministry of Health and all the provinces to cover 100% of the cost. They've always come back and said that they like to refer to it as a cosmetic appliance, which I think is a complete misdefinition of what an ocular prosthesis actually is. And the easiest way to say it is like, can you go without it, or do you feel comfortable going without it? And to that answer, they've always kind of shrugged it off. But I think it's an important factor to the patient if it comes down to the cost a cost issue, then that's not really fair to the patient, especially when it's a child, and to the family as well. And then the other side to it is that because there's a couple provinces that have no coverage at all, how, at least in the Ministry of Health in Ontario, they'll look at all the provinces and the different pricing across provinces and then evaluate those. And because there's some provinces that have no coverage, they'll look at that and kind of reflect back and say, well, then we're covering 75% of the cost, so that should be adequate, which, isn't really fair. So I mean, I've always thought that it should be 100% covered, because it's not a choice to wear an ocular prosthesis, and cost shouldn't be that factor.
Yeah, absolutely. I agree. And I feel, and here's like something that you shared with me, Matthew, if you did you want to?
Yeah. So this is as of June 7th last year, the pricing of ocular prosthetics was reevaluated by the Ministry of Health. And they raised pricing based on material costs, rental costs, cost of living, those types of things. So prices have gone up. They're still relatively reasonable compared to other countries, but especially the United States. And this is the total cost on this form. So the patient portion would be 75% of this cost, as they'd be required to pay as a copay element to it. So unfortunately, I mean, we have the Ministry of Health has tried to keep it somewhere within or kind of a reasonable cost for patients, but unfortunately, as rent, especially in like big cities like Toronto, as prices have gone up, they've had to raise pricing just to kind of maintain clinicians being able to work in a private setting. So.
Yeah, and I mean, some considerations that I took from the article as well. With this being said, as Canadians, we should have a guideline of how often younger patients need to visit an oculist, and not necessarily rely solely on an as-needed basis. And this ensures that certain things can be rectified before they become problematic later in life, resulting in possibly even reconstructive surgery, which can be really detrimental to the social and emotional, I think, component of a patient's life. I mean, I can't imagine going through something like that again for the second time, just because of some facial incongruence or something that has to be rectified because of not going and maintaining an appointment. So I thought maybe a passport similar to the yellow immunization card in Ontario, with like a timeline of expected routine follow-up appointments, would be beneficial for a new patient. And then I spoke briefly with Ivana about this, and she mentioned that it would be such a great idea to be included in like the retinoblastoma guidelines of care, even possibly. The other thing that I thought of, due to the cost associated with it, universal coverage across Canada should be considered at the federal level to encourage a better pathway of care for follow-up after enucleation. And this can ensure patients are waiting for an appropriate replacement time in between ocular prosthesis and maintenance of their prosthesis, and avoiding any delays. And I thought, what are some ways that we could do this? We can lobby for change by starting a petition on change.org. I mean, why not? So many people create petitions about anything these days, but this is a really, really important cause, I think, especially to our retinoblastoma community. And the other thing that we can do is send an email about our concerns to the Assistive Devices Program. And Matthew mentioned the two different emails that you can send an email to: adp@ontario.ca and Assistive Devices Program at one-mail.on.ca, and that is all in the presentation slide. So if once the presentation's over, if Ivana wants to upload the slides on the website, that would be okay. But that's pretty much what I just thought, how can we make an impact? So please feel free to share your story and help us bring change to patients with ocular prosthetics, because we want to be the change we want to see. And there's no pun intended there, but be the change you want to see. So that concludes my presentation. do we have time for Q&A, Ivana, with Matthew?
Yeah,
Okay.
we do. We have about 15 minutes.
That's great. Okay.
I'll start by sharing in the comments. There were some nice stories that aligned with your story about your son putting his prosthetic in his mouth, and Marge also said that her daughter too put her in her mouth once and scared us. And then Lynn mentioned her dog ate her prosthetic twice. So definitely some funny stories. But if anybody else has comments about anything Talene and Matthew shared with us today, or if you have any stories you want to share with the group, you can either raise your hand or just unmute yourself. I wonder if anybody who's out of Ontario wants to share their experience and let us know, especially if anybody's from Saskatchewan or Manitoba, and how maybe those experiences are, or if anybody's connects with patients from those provinces, if they can maybe shed some light on how they're supported.
So I see a couple of patients from Saskatchewan, and a lot of them will have private health. Like some of the patients I've seen have private health insurance that will provide coverage for it. But it's really that kind of pushes the socioeconomic decision to a more extreme level, because it's all or nothing as opposed to 25% of the cost. So unfortunately, in some of those provinces, it's just whatever the policy decision is, it's to not cover it. But it really calls into question of the ability for parents to pay for prosthetics for their children, which is really not fair. The other thing I was going to cover with I thought the article and Helen's coverage of it was really, really good. The one thing I would say what they didn't really cover was that first recall appointment. And what I always do is whenever we fit a new prosthesis, especially for the first time, is follow up within 1 month, because we want to make sure that it's fitting properly right away. Make sure that there's no irritation or problems, because if you can catch something early, it's a lot more beneficial than trying to catch it when it's too late. And so whenever you fit a new eye, I like to kind of follow up right away. And they didn't really cover that in the article, which I mean, I think they did a very good job of covering kind of the general follow-up periods, but there's certain times when you want to follow up quicker, like a new prosthesis. And then the other side to it is that I always try and educate the patient's family regarding what to look for if there's an issue like irritation or discomfort, because with the children that we're dealing with retinoblastoma, they can't always vocalize exactly what they're saying, what's going on. And so I think a lot of it is up to the parents, and sometimes parents, and as you saw with Talene, she's emailed me pictures and say, does this look right? And that's kind of part of that two-way communication from the ocularist to the parent, saying, is something going on here? And then you can address it right away and have if it need be, bring the patient back in sooner. And then you can address these issues before anything gets worse. So.
Great comments. Dr. Galley, I see you have a raised hand.
I'd just like to ask Matt if he could describe a little bit of how he has the children become so comfortable with handling their eye and having their eye handled in his experience, from babies to older kids.
Yeah, absolutely. That's a great question. I mean, working with Dr. Galley, we've always had a very kind of open communication line with kids and with parents. I think one of the biggest things is to not put any sort of stigma on it. So never trying to hide it. Always try and be very positive. I think words really matter. So talking about their special eye as opposed to their fake eye or anything like that. So I think, and then having children be part of the whole process. So I think talking to them, even if they're kind of too young to totally understand what they're saying, involve them in the process of making the eye, fitting the eye, and then congratulate when they do positive things, and always try to make a positive experience out of any sort of interaction with the prosthesis. So I think that's an important step for them, feeling kind of self-confident about it and getting comfortable with the entire process. And then having the parents get comfortable as well. So answering as many questions as you can to parents so that they become their own kind of professional at how to interact with the prosthesis itself. The more confident the parent is, the more comfortable they are with that process, that's going to reflect with the child as well. The child's going to feel that kind of comfort level, and it's going to get easier with them as well. So I think those are the two big steps to helping with the child get used to the prosthetic.
Thank you very much.
I see another raised hand from Vasudha.
Oh, hi, I'm Vasudha Arvind. I'm a pediatric ophthalmologist in Saskatchewan. Earlier, you were asking if anybody from the prairies could speak. So our ocularist here is John Corosal. And what I do for the coverage for prosthesis is I just write on a plain prescription as if I was prescribing an antibiotic drop or something. I write it on that and give it to the parents, and I also fax a copy to our ocularist, so he has it ready by the time the patient gets there. And they, unfortunately, it's not covered, but when I give a prescription, they can submit that and they get some amount of coverage. The problem is more so when the patient is living in a very remote area and there's no other ophthalmologists in those areas that can see. And unfortunately, optometrists don't have much experience with ocular prosthesis. So those are the tough cases. And now that, in a way, thanks to COVID, virtual care has become, more sort of the norm. That's one thing that I'm thinking we can do more often is patients who are in remote areas who would actually have to take a plane and fly to Saskatoon or travel over a day. We could do like a phone, like a webcam session, a virtual session, and maybe I could help them through that. It's just you can't do a slit lamp exam with high magnification, but so that's just what I wanted to add. Thank you.
Thank you for sharing that. I see Alyssa also has a raised hand.
Hi there. Hi, I'm Elisa, the social worker with the RV team at Sick Kids. And I would just suggest that if there's families, regardless of where you're living in Canada, if there really is a serious cost constraint regarding the prosthetic, that you may also consider reaching out to your social worker if you have one, or seeing if there is someone that you could speak to. Although there's never a guarantee that that there will be funds available, there sometimes are some really good, even small charitable organizations that sometimes can help. And I know from even looking into this issue regarding funding, it varies as you already others spoke about it. The funding really varies so greatly among the provinces. It's really a very disappointing situation. So I would certainly encourage families to reach out. I wouldn't want a child to be going, without or receiving less than optimal care.
Thank you, Alyssa. Now, I don't see another raised hand right now. So I wanted to ask Matthew, when we were reviewing the article together, you were mentioning, sorry, the names escapes me, the email that Helene shared with us. So the organization.
The ADP.
Yeah, and how you mentioned how it was important that they hear from the patients themselves and the families.
Absolutely.
If you wouldn't mind sharing that here with us again.
Absolutely. No, that's a good point. So the with ADP, we have kind of as vendors with ADP as Ocularis, we have regular meetings with them regarding kind of funding and coverage and procedures and those type of things. The issue that they have is that they're really their customer, their focus is on the patient. And so if patients want changes made to ADP, they really they want to hear from patients to make those changes, right? So unfortunately, artificial eyes is a small group, but you can still have a loud voice. And the more that they hear you, the more that they're going to have a better chance of changing some of these policies. Like as oculators, we've tried to bring them along to kind of full coverage and explain the requirements that the economic requirements these patients cover. But when they look at they really want to hear from patients. And if they hear from multiple patients about the difficulties that they're having, they're more likely to make changes to their policies. So that's what I really, when we're talking to Talene and Ivana, that's really kind of where we're going to get movement on these issues. So you can write an email. They actually want to hear from patients. They talk in these meetings about how they generally want feedback. They want to make positive changes to these programs. The people running these programs do want to, ultimately make the procedures better for their patients. But it's just a matter of they need that communication. It's got to come in. Yeah, so you can email both those emails. They'll go into their system, and they do have departments that can handle patients' requests for changes.
Thank you for sharing that part. I think it gives us the power to try to make a difference at least. And I think sending an email is not a very hard task, at least, especially if it could help make a difference. And then when I was thinking about the comments that were made about the different families, it might be easy when people are being seen in clinic, but then once patients are out of a clinic, and they might not be seen on a regular basis. And if they do need a prosthetic, it might be a lot harder to get a prescription or to sort of go down that road where they could find either the financial support they need. So I feel a bit empowered here. I think I will definitely try to send an email to them. Hiral, I see.
Yes, do we have time for one more? I think there is someone with their hand up.
Yeah, Hiral, you'll be the last one here with us today to share. Go on.
Hi everyone. Good evening. I had a question. So is there any time period, like how many days, if something happened to the prosthesis and if we lost it or damaged it, how long we can go without it, which doesn't impact the eye socket or like that? So I'm always wondering, because if I need to fly back home country, and if something happens with the prosthesis there, I cannot immediately fly back. So what are the options if we are in that kind of a situation?
I can cover this. So great question. So, we're talking about kind of the long-term effects of orbital change. So if the prosthesis is out for a couple of days, it's not going to cause any orbital malformation. Mm-hmm. Depending on what's wrong with the prosthesis. So if it's lost, you can't do anything about it. If it's damaged, you can kind of see what's going on with it. The best thing you can do is kind of reach out to your oculars. I do a lot by email nowadays in terms of the first step communication. So it's not always bringing someone in. It's like, what's going on? Take a picture of it. Let's see if we can discuss it.
Yeah.
And go from there. Depending on what's wrong with the prosthesis, if it's just kind of a little bit scratched, it can be okay to wear it for a while. If it's actually kind of cracked or obviously lost, then it should be replaced. So I'd say you don't want to go any more than kind of a couple weeks, in an emergency situation without anything.
Okay.
But that'd be the kind of the time frame I would say would be reasonable to kind of get back and see someone to address it. I mean, ideally it's less. If it can be less, but in an emergency situation, a couple weeks isn't going to have any sort of long-term effects to the socket.
Yeah, we haven't planned any travel yet, but that is something I have been wondering about, because if I need to fly back into India, and then I won't come back if something happens immediately.
So the other thing is what I always do is, at first eye, there's not much you can do. With once you have kind of a second eye made, I always tell patients to keep the last one that they've had and bring that with them on vacation. I have had patients on vacation who've lost their eye or had something go wrong with it. And if they have a spare, it doesn't ruin the vacation right away. So just kind of bring it with you, keep it, and then if you don't use it, great. If you do use it, then you don't have to kind of fly back immediately. So that's kind of the next step once they have a secondary prosthesis.
Yeah, that's a good idea. This is our first one, so but yeah, that is a good idea.
Yeah.
Thank you.
But I mean, as long as it's fitting pretty well, it's unlikely that it's gonna kind of, especially when they're young children, they're not gonna be anywhere where you're not. So it's unlikely that it's gonna get too lost. And now when you're older, it's a lot easier to kind of lose it in different ways. But
No, that was a great question. In fact, a really great discussions from everyone. Thank you for everyone who attended today. Stay tuned for our next cup of tea, which is planned for September. And if you're interested in creating a plain language summary and presenting at a cup of tea, you can send me an email. It's ivana.ristevsky@sickkids.ca. And you can stay up to date as well on our social media at RB_research or at RB research. And please also visit our website. You'll be able to see the link to our plain language summaries and our Renobostoma research community. Thank you guys so much.
Thank you.
yeah, thank you.
Thanks.